Well, I think it's no surprise that the pandemic has negatively impacted everybody's mental health, some more than others, but really understanding that this uncertainty that we're living with is just it's just not good for our brains. And then you add in everything else, and actually long-term COVID also has led to a lot of depression and anxiety as well. So our first focus is kids, because kids have struggled the most. And so we are actually having a press conference on Tuesday on this issue, but we want to make sure that we're really helping them. So we have things like we have a school linked mental health program that is a model in the nation. The funding actually goes to a mental health provider who co-locates in the school. So we have HIPAA records. We eliminate barriers for families in terms of accessing the care. So continuing to increase those. Also, school support personnel, they're an important part of our school buildings, and also making sure that we're not suspending, especially little kids K-3, but providing social emotional learning instead. Suspending them doesn't teach them anything. And the more you get disengaged from school, especially by grade 3, the less likely you are actually to graduate. We have a bill up this week to create a lead within the Department of Education on mental health for both teachers and students, so that there's kind of one place to go if you need support. And then really looking at some of the community supports, like creating crisis homes for children, respite care for families so that they get a break. We'd also like to have respite care for parents who live with a mental illness, because this has been a difficult time for them as well. And then we have the first psychotic episode program. We want to also expand that to the first mood disorder program, so that we're really providing the most intensive services possible for some of the most disabling conditions in the world. And so kind of pushing those. I will say, though, that we can do all this, but we don't have people to do the work. And so last year, we actually worked very hard on creating a more culturally diverse and informed workforce. The first grants actually were released this week, so BIPOC mental health professionals can apply and use that money to become a supervisor, so that we have more supervisors in the field, which will help more young people kind of coming through. But this year we're doing things like we want to pay for supervision, because that usually comes out of their own pocket, which makes it really impossible to get licensed. We want to create incentives for mental health practitioners who've been in the field for 2 years to actually go and get their master's, so they can become mental health professionals. Really increasing the dollars for the health professional loan forgiveness program, which includes all mental health professionals. And last year we added licensed alcohol and drug counselors. We also want to increase funding to train more peer and family specialists. If you've done this, you've been in this either for yourself or a family member, you're really good at engaging others and helping people kind of understand what they need to do. And then we want to increase funds we have a grant program that uses federal block grants that goes to culturally specific mental health organizations, so that they can kind of grow your own, provide supervision, all of those kinds of things. But we want to add more money to it. To make sure that, again, we're continuing to build both the cultural diversity of our workforce, but the workforce overall. We also have a bill that will expand network adequacy for insurance plans. So health plans in Minnesota, it's 30 miles, 30 minutes. Doesn't mean you have to have an opening. And so they can say, well, we have mental health providers in our network, but they don't actually have openings. And so we're just saying, during these next 3 years, since we really are in a mental health crisis, you have to open up your network to anyone who's willing to accept your payment rate and who meets your qualifications. And in the interim, we'll have the Department of Commerce and the Department of Health look at what other criteria can we use to ensure network adequacy. I also want to say we have a huge bill that's actually up this week around competency restoration. So this is an issue, frankly, across the country. I actually sat on a national task force. So we have a whole lot of people, more than ever before, who are deemed incompetent to stand trial. But if it's a misdemeanor, you're basically released, because you hit that 90 days, and constitutionally you can't keep people longer. Different things if they're felonies. And what they often do is they'll take the people who are deemed incompetent and then see if they can commit them. Hardly anyone is committable. They don't reach that standard. So instead, what we want to do is actually create forensic navigators. So people who are part of the court system, but actually understand the whole social service and mental health system, who, even if they're not going to charge the person, because you can't, will actually connect with them and try to get them connected to treatment and housing and food and all of those other kind of supports that keep people from cycling in and out of both the emergency room and, frankly, the jails. And I do want to note that most of these crimes are not violent. I know that the media has focused on a couple of really tragic situations, but most of them are nonviolent. And so if we can connect people to the treatment, they will actually do a whole lot better. One other thing I do want to mention, because people are talking about a lot, is hospital beds. Yes, we need more. And there is a study out there that says Minnesota has the fewest number of hospital beds per per person. It's not true. They only counted state operated beds, which is a very small part of our mental health system. And while we need more, we need them in the right way. So Children's Hospital is proposing adding around 22 to 24 beds within their hospital on the St. Paul campus. Great, we need them, and they don't have them. But then we have Fairview that is recommending building a psychiatric only hospital. In case you haven't noticed, our head is connected to the rest of our body. And many people with a serious mental illness also have things like diabetes or COPD, because there's a high smoking rate among people with schizophrenia. If you're homeless, you might have a fungal infection in your feet. We have to treat the whole person. There's also no emergency room, which means they can decide who they're going to take, which could actually create an imbalance in the payer mix of our other psychiatric units. And that has actually led to closure of units in other states. And then lastly, there is a weird part of the Medicaid law. It's called Institute for Mental Disease. And you can't use Medicaid to pay for mental health or substance use disorder care in any facility with more than 16 beds where more than half of the people are being treated for that. So for example, we don't usually use Medicaid or can't use Medicaid for things like the Anoka Regional Treatment Center. If you look at the residential facilities in Minnesota, there's 16 beds for that reason, so we can use Medicaid. So technically, they're not going to be able to use Medicaid at that facility, except under very limited situations, like if someone is on managed care, Medicaid, and it's less than 14 days. So this is not the kind of program that we want to build in our state, despite the fact that we need more beds. Our mental health system is not broken. If you look at the history, it was never built. And so what we need to do is to continue to build our mental health system to meet the needs of Minnesotans. The nice thing about working on mental health issues is it's bipartisan. If you look at the first, Mental Health Parity Act, it was, Pete Domenici and Paul Wellstone. You couldn't be at, two polar opposites in the two of them. And so that actually really helps us. We have made progress under both Democratic and Republican administrations. The real problem is that the needs are huge, right? So you have nursing homes saying they don't have staff. You have childcare saying they don't have staff. You have schools saying we're losing teachers. You have hospitals saying you don't have staff. So we have this huge workforce shortages across all these different areas. And so you have competing needs, and that's what makes it really hard. I will say that there was a bill up this week that looked at, let's create a new behavioral health agency. And honestly, to me, it's like, I don't want to spend any time rearranging agencies. Plus, Medicaid is such an important funder for mental health that it needs to stay within the Department of Human Services, not separated from it. If anyone's tried to work across agencies, you know how hard that is. It's hard enough within an agency. So that's the problem. We have some ideas popping up that a lot of the mental health community doesn't like. And then we have all these unmet needs in our community that we have to compete with, and all are valid needs. And you can't work on recovery if you have unstable housing. So, they've seen that people who are cycling in and out of emergency rooms and jail, they did this project in St. Cloud. They just picked the people who were the highest utilizers. Most of them didn't have housing. Once they got them housing, they were able to stabilize them, and they stopped all that. So we know it's a huge issue. We have a separate program called Bridges, which is basically a Section 8 housing for people with mental illness. There's waiting lists. We always go in every year to try to get more money. We've also seen things like supportive housing is really helpful for people who have more serious mental illnesses. I will say that the Department of Human Services makes this very difficult because we usually use what we call waivered services to pay for the kind of supports that someone needs. If you have ever been to Rising Cedars that Touchstone owns right off of Franklin and near Hiawatha, it is a beautiful program. You have, about 30 apartments. I mean, I'd live there. They're really nice apartments. It doesn't feel institutional in the very least. But yet the department is calling that an institution. And what we hear from people with mental illnesses is the 4-bed corporate foster care settings that some people call group homes, much more institutional because you're sharing a living room, a bathroom, you know, a kitchen with 3 other people that you don't know or like. And so we really do like this other model, but we have a hard time actually expanding on it right now. But the other types of supportive housing can be really good too. You know, not everyone lives alone. And I think that this issue about, you know, fully integrating people with mental illnesses or people with disabilities into the community means everyone has their own apartment and lives alone is actually not, that's not everyone's experience. Not everyone wants to live alone.